Thank you, Kirk. And thanks for coming out tonight. I think the stage has been set by both the prior speakers, Dr. Meng and Dr. Schramm. So makes my life a little easier here. So without further ado, I'm going to jump into my slides. And let's see if I can work this. Okay, perfect. So my first slide basically gives you a little idea of what the risks leading to death in perspective are. And here you can see that the risk of me being afflicted in war and having mortality, that's the size, and if you go down there, illicit drug use, being in a transport accident and dying, and if I had an infection, my risk is this size, and you can see what the risk of hypertension or high blood pressure is. This is from WHO data saying this is what the burden of disease is today and what the risks of dying or dying from these various entities are, and hypertension is the leading cause today worldwide. And the two prior speakers alluded to it in the causes as well. So, going front. All right. So, the story is pretty long. It was first thought about that it's kidney disease that drives hypertension. That came from Bright's disease. And Bright described this disease as inflammation of the kidney that was after an infection that led to kidney failure and brought about hypertension. But then came the understanding that hypertension can occur without renal disease, and that hypertension can be causative of renal disease. So it's not that renal disease causes hypertension, which is true, that renal disease can lead to hypertension, but hypertension can lead to renal disease as well. And then in the early days, there was misconception that hypertension may be an important compensatory mechanism, which should not be tampered with, even if it were certain that we could control it. So a lot of people thought this was part of the aging process. And we were told formulas that you can, minus, 200 minus your age is your normal, or we used to calculate all these things and say, you're okay with 160, you're okay with 180 blood pressure. So we used to do all of those things in the early days and when I was in training, but things have changed. So in a cardiology text, there was this quote that the greatest danger to a man with high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. So you see that we came from that kind of background where we said, leave it alone. In fact, I think one of the presidents of this country was left alone, not treated, and passed away because of untreated hypertension. I think it was FDR. The reason that we named it was there's an entity called benign hypertension. Hypertension is never benign, but we called it benign hypertension. Even today, I get notes that say benign hypertension. It's not benign. Hypertonia essential. Again, it's essential. It's kind of part of the story. That blood pressure is a symptom and not a disease and should be left alone. So these were some of the early misconceptions. Before the physicians even recognized hypertension as a cause of mortality, the smarter guys were the actuaries. The actuaries are the guys who calculate your risk of death and issue your insurance policies. Those guys were watching this very carefully and quickly recognized that they wouldn't want to give insurance policies to anybody with hypertension. They knew that they're taking a risk. Meanwhile, at the same time, in 1925, our textbooks were saying, oh, it's just an age-related phenomenon, leave it alone. And in 1940s, we had the first data that came out that said mild hypertension, shortened lifespan. So then we went on to looking for what the cures could be. And it was pretty brutal. So people didn't want to be treated because we were excising their thoracic ganglia. We're pulling out organs out of there. We're resecting their nerves. We're dissecting their sympathetic ganglia or taking the adrenals out. We'd give them shocks up the wazoo or irradiate their adrenals to just burn the adrenals out so that they will always be hypotensive. So the blood pressure, you achieved the number, but the guy couldn't get off his bed. He couldn't walk straight. So we were doing things that were kind of interesting during that age, and that's why was the averseness to treating blood pressure. It was not easy to treat. Early drugs were no better. These were drugs that were using the treatment for syphilis or malaria or barbiturates that were knocking the people out, thiocyanates that were toxic, bromides and bismuth that could be nephrotoxic. So we were using agents that were having effects somewhere else while lowering the blood pressure. But then things began to kind of turn around. But some of the early approaches included treatments like watermelon and cucumber seeds, mistletoe and garlic, and red meat and sex were forbidden. My God, what a life. Now, it's interesting to note that, this is a phenomenon of affluence. Our affluence is a curse on us. In the industrialized world, the incidence of hypertension is 5% young adults, but 20 by the age of 50 to 60 everywhere. And as we have now revised the guidelines, it's jumped up to almost 50% by the age of 50. And at age 80, it's almost like 80%. This slide is old, but that's where we are. But if you look at the non-industrialized nations, they're doing better. The Yanomamo Indians in the Amazon basin, their blood pressures run in the 90s systolic, 70 diastolic. If I went there and they measured my blood pressure, I'd be admitted to a hospital on 120 or 80 as a hypertensive emergency. Rural Zaire, Botswana, Kalahari Bushmen. And all of these guys basically have a very low salt diet. Their diets do not have salt. That's one of the key things I think the early speakers alluded to, the effect of salt. This is what it is. These guys eat fresh fruits, fresh vegetables, they hunt themselves, they grow their foods themselves, and salt is unavailable. In fact, these people actually show an age-related decline in blood pressure. Very interesting. Whereas we show an age-related increase, and it's kind of common now. After the age of 55, the systolic shoots right up. The increased risk from hypertension is to entities like heart attacks, stroke, kidney disease, dementia, and cognitive decline, peripheral arterial disease where the arteries of the legs begin narrowing, aortic aneurysms. So there's risk of a lot of entities being affected by hypertension. And the causes are many. It's multifactorial. It's not just that the kidney drives hypertension, but they could be many. It's genetic, we talked about it, diet, environmental lifestyle, we've talked about it. The renin-angiotensin-aldosterone axis. The aldosterone is one of the prime movers of hypertension. Aldosterone is released by the adrenals, but the potent stimulus comes from the kidney, which makes the hormone renin. And that renin drives the aldosterone up, and aldosterone can be very potent in driving the blood pressure up. Similarly, the role of the sympathetic nervous system, whether it's coming from sympathetic drive in my brain. We also know that there's a sympathetic nervous system in the kidney that can be upregulated as the kidney shrinks in size. If the kidney is affected or damaged, there are sympathetic outflows that go up and raise blood pressure. And there are now modalities coming out where we're trying to burn the sympathetic nerves in the kidneys as they come out of the kidney to see if blood pressure drops. And in the European trials, they're very successful. The American trial failed, but we're still looking for good outcomes. And I think you'll hear more about the sympathetic nervous system and the kidney in the near future because it's called renal denervation. And these are all device-based therapies, not medication-based therapies, but a device that utilizes radiofrequency ablation in the kidneys to ablate or burn out the renal sympathetic nerves that come out of the kidney and therefore drop blood pressure. And the initial studies were pretty promising. The role of kidney function itself, as kidney declines, as the function declines, blood pressure goes up. As the blood pressure goes up, the kidney gets hit. So it's like a vicious cycle, and we'll talk about it later. And in those drivers are the role of volume and salt. We talk about, I think one of the speakers alluded to African Americans being a special consideration, and that's true. They develop blood pressure much earlier. They develop much higher blood pressures. They develop much more target organ damage. The kidneys are damaged much quickly in them. And they're harder to treat. And that's because they're predominantly volume and salt driven. They're salt sensitive. What I mean by salt sensitive is that their kidneys have an innate ability to retain salt. They have like a cycle in that. They just kind of resorb the salt. Like, for example, the other populations can dump salt effectively. The African Americans have a tough time. They'll retain the salt. When we retain salt, we retain fluid. When you retain salt and fluid, blood pressure goes up. And that's what primarily the driver in African Americans. Hormones, almost a whole host of hormones. Any steroid hormone that's produced by the body, the thyroid hormone, the adrenal hormones, all of these hormones will drive up-regulate blood pressure. Poor sleep hygiene, we talked about sleep apnea as a driver. Not just that, I think in the years to come, we're going to have Facebook hypertension, Twitter hypertension. We're going to have all these hypertensions being driven by social media hypertension. And all of these are because of poor sleep hygiene and our screen time. I think we're going to see it. It's coming. I see it in my kids. I want to smash their phones, unable to get it. Stress and anxiety. Drugs, there are good ones and the bad ones. We alluded to cocaine. But there's a whole host of drugs. And we'll look at that as we run the complex hypertension program here. we always are looking at what kind of drugs may be interacting. It's one of the first things we do in our clinic is to look at the list of drugs, declared or undeclared, to see if there's something driving the blood pressure. When you look at other causes of high blood pressure, there are many, and we've talked about them. So I just alluded to the role of aldosterone and the role of thyroid and the adrenals. And then, of course, other entities where there's narrowing of the blood vessels or driven by drugs or growth hormone. And then in pregnancy, and then other organs like the parathyroids, in addition to the thyroids, where the parathyroids are organs located at the four corners of the thyroid that can be upregulated in kidney disease and then be the driver of hypertension. So often we're looking at the parathyroid levels. If those are elevated, we go ahead and treat them because we know that we're going to get some success in blood pressure treatment. Now coming to drugs, as I said, one of the common things we see is that people are taking multiple agents for different things. Steroids, sympathomimetics, nonsteroidals, immunosuppressive drugs, epogen, herbal pills, licorice, chemotherapeutic agents. And I'll simplify this for you with the next slide, which says, this is where we're using them. When we use contraceptive pills, blood pressure goes up. Bodybuilding activity for anabolic steroids, or giving anabolic steroids to people who are losing weight. We use it all the time in our dialysis population. We use Megace to get them to eat. We're trying to increase their appetite, but we end up driving the blood pressure up as well. Asthma treatment, COPD treatment on steroids, any other collagen vascular disease or immune disease, autoimmune disease treated with steroids, blood pressure is going to go up. Painkillers. This is one of the biggest ones I look for. And I'll give you a list of the medications as we come up. Cough syrups, antidepressants, transplant drugs, cocaine, licorice. Licorice comes in different forms. If you're traveling abroad, you could be picking up licorice from some other country. In this country, it's highly regulated. US regulates its licorice by only allowing deglycerinated licorice. But the rest of the world uses pure natural licorice or a licorice extract. The Chinese use it to have a syrup as a sweetening agent. So while you may be using a cough syrup, the sweetening agent may be licorice extract. And that's the sweetening agent. It's going to drive your blood pressure up. So anti-cancer drugs, the newer drugs, we're seeing it all the time now. People being treated for cancers are coming up to see us for new onset hypertension. And the clue is that they're on chemotherapy. Here's your nonsteroidals, commonly used: Advil, Motrin, Voltaren, Feldin, Clinaril, Frotec, Daypro, Relafin. So you can see the list goes on. Some of them are more, I can tell you where these patients come from. Right after their knee replacement, I see them on ketorolac. That'll drive their blood pressure up and injure the kidney as well. If they're seeing a primary care physician or primary care practitioner, I'm seeing a lot of Mobic nowadays. It's one of the popular drugs. I guess the drug reps are bringing a lot of lunches there. But you always picking up these names. You got to be very careful. It may be a benign name. I used to think Daypro was a benign drug, till I looked it up and found that it was a nonsteroidal affecting the kidney function, and also the blood pressure. Take it away, blood pressure is great. I have several patients that I've taken off of Mobic that have normal blood pressure now. Just a simple, straightforward intervention. Recognize the drug, take it away, and you see it. I know that these agents do give a lot of relief for osteoarthritis, and they're necessary. So sometimes we got to take a balance, and we're always having to make that adjustment, and we can see what other drugs they are on, and then make the adjustments. In the kidney, we see many diseases that will drive blood pressure. These can be acute and they can be chronic diseases. In the acute side, we see the, hypertension being driven up by post-infection conditions. It's called post-infectious glomerulonephritis. We see it in other entities of the kidney which are acutely affecting kidney function, and then we see it in chronic entities of the kidney where the kidney itself is the tissues being damaged. As the tissue damage occurs, we see that the blood pressure continues to go up. And this could be conditions like polycystic kidney disease, hydronephrosis, dysplastic kidney, or kidneys that are affected by just an allergic response, allergies within the kidney. Because the kidney will react to an infection or a drug by having an allergic response and then destroy the kidney tissue. Chronic kidney disease and hypertension intricately linked. hypertension is present in 90% of patients with glomerulonephritis, 60 to 80% with the allergic kidney disease, and in dialysis patients, it is almost, in dialysis patients, which is, whoops, sorry. In dialysis patients, almost 100% of patients on dialysis will have hypertension. So hypertension belongs to kidneys all the time. Any kidney disease, we see hypertension always there. In terms of seeing a group of dialysis patients, when I walk into the unit, if I have 100 patients in the unit, almost 25, one-fourth of them will come from hypertension-driven kidney failure. Hypertension leads to about 24-25% of our patients. 41% comes from diabetes. So in all, diabetes, hypertension lead to almost 2/3 of our population coming together with diabetes and hypertension leading to kidney failure. The tissue disease, basically, when tissue is affected, when the tissues are affected, we can see that it's almost like a vicious cycle, because while the blood pressure drives the kidneys to be affected by sclerosing them or shrinking them, the shrinking kidney itself drives blood pressure up. And that is very well described in the simple slide here that shows you that chronic kidney disease drives blood pressure, and blood pressure in turn drives kidney disease, which basically means that the kidney becomes both the victim and the villain, and hypertension a consequence and cause of renal function loss. As the renal function declines, the kidney loses its ability to regulate blood volume. The blood volume climbs, you see swelling, and you see high blood pressure. There are other vasodilators or dilators of the vasculature that are produced by the kidney that are not being made. Therefore, the blood vessels can't dilate, the blood pressure goes up. There are certain vasoconstrictors that are metabolized by the kidney. These are agents, vasoconstrictors are those that constrict the blood vessels or make them narrow. Those are metabolized by the kidney, but when they're not metabolized, those elevated levels of vasoconstrictors again lead to kidney disease. So there's a lot of things going on in the kidney in terms of hormones and the fluid volume and the salt retention that eventually drives blood pressure, which drives the kidney disease. Eventually leading to a leak of protein, which is one of the first things we kind of see. It's one of the most common things we will check for in our patients to see how much protein's coming out. One of the earliest predictors of mortality in patients, cardiovascular mortality, is this leakage of protein from the kidney. So the kidney is like a mirror is like a telescope into the body. Because if the kidney is leaking protein, you're leaking protein elsewhere, in the brain, in the heart, and elsewhere. It's leading to accelerated atherosclerosis or aging or blockages being formed in elsewhere. But the protein is then a marker for more to come. And I think one of the key things here is to check urine for a presence of protein, to then say there's something going to happen. We know that we are catching you early, and it's time to make changes. Blood pressure is very poorly controlled in most of our patients. You can see that almost 2/3 are never controlled. How do we get to goal? Or how often do we get to goal? Only about 40 to 60%. If you have a good program, it depends on the patient population. It depends on the aggressiveness of the physician and the number of drugs being used. Remember that 2/3 people, almost 75% patients in this country, will need 2 or more medications to control blood pressure. So if you're on a single agent therapy, consider yourself lucky. If you're controlled on one agent, consider yourself lucky, because most patients in this country are on 2 or 3 pills to control their blood pressure, and that's normal. That's the norm now. The age of the cohort, the comorbidities, other illnesses in who you're treating, and the starting point. If your starting point is 180 and using one agent, not going to get it. We're not going to get goal. If your starting point is 140 and you're trying to get to 130, you're going to get to goal. So where we're starting defines how often we'll get to goal. How do we get to goal? We talked about it. Dr. Reza Shram talked about it. Use medications, use more than one medication, and then use more than one medication wisely. How to use them, when to dose them. How many times a day? What's the right dose? Often you're using the right pill, wrong dose. Right pill, wrong time. Right pill, wrong frequency. Okay, it's telling me I've got my 20 minutes are over. Okay, so, well, I didn't mean to jump out of there, but let's get. So here, so we're almost done. And I think they've alluded to, so I don't need to talk much about weight, lifestyle modifications. But here's what I'll just add on to what they've said. If you look at all the things you could do today, weight loss, salt restriction, calcium supplementation, potassium supplementation, magnesium supplementation, high fiber, low fat, fish oil, garlic, alcohol in moderation, exercise, relaxation and biofeedback, or the DASH diet, where are you going to get the biggest bang for your buck? If you're going to pick one of these things to do today, while you go home today, you got to do one of these things. It's not exercise, it's not weight loss, it's not the calcium, it's not the potassium, it's not the sodium, but it's the DASH diet that'll give you the biggest bang for your buck. Okay, so just focus, go back and go out today and look for the DASH diet. It's not that hard, it's not a bad diet, it's pretty good, and you can do it. Okay, so take home pearls for today. One thing I always do in my clinic, I always do a nighttime dosing of drugs. If it's a once a day drug, we're going to dose it nighttime. We're not going to dose it in the morning unless it's a diuretic, which is a water pill. It's a diuretic, it's going up in the day. But if it's an ACE inhibitor, an angiotensin receptor blocker, a calcium channel blocker, those are usually once a day drugs, are usually going to be given at nighttime. There's enough data now that shows it does no harm, if at all. It will provide you some benefit on multiple fronts. So nighttime dosing. So if you're taking a pill, if you know somebody who's taking a pill and they're not getting there to goal, try and dose it at night and see how you get to goal. Watch the painkillers. Watch what you take off the counter. The Advil, the Aleve, the Motrins, the ibuprofen, the Celebrex, all of these are driving blood pressure up and also affecting kidney function. Often we can make an adjustment. Often we can make a compromise and help people lead lives, but also not affect their kidneys. Watch the best strategy is DASH diet. We just talked about it. Watch the salt. Where does it sneak in? It's in the bread. That's your highest source today. Bread and pizza, bread and all these carbohydrates. We're a carb toxic nation. We're all carb toxic, and that's where it's coming from. Commercialization has led to salt being added to your milk. Your milk is salted as well. That's what gives it a shelf life that says expires on 1st of March. We're on the 12th of February now. Today you're buying milk that's expiring then. Refrigeration, pasteurization, and salting. Salting is what extends the shelf life of all of these things. And if I was a businessman, I'd salt the hell out of everything to sell it to you guys. So, watch the pills. Whenever you're adding a pill, call your physician, talk to your primary care physician, ask him any interactions. If you see that your blood pressure has become poorly controlled after addition of a pill, last one in is the first one out, okay? So that's what you look at. What was the last pill you added? My blood pressure went out of control. So that's one of the easy things to do. And now what's coming in is device-based blood pressure therapy. We're using this agent called Respirate. It's a biofeedback. I think Dr. Schramm talked about biofeedback, and that's what we're doing. We're prescribing Respirate. It's not covered, but it's a great device. It's biofeedback. It upregulates your parasympathetics and decreases blood pressure, especially if you're one of those that uses one agent therapy. Single agent therapy, if you're on one pill, you can actually dump that pill if you started using this agent. It's well recognized now, and there's more to come. There are new therapies coming for blood pressure intervention, which are device-based. Hopefully one day we'll get to do a talk about it. But I'll stop there and we can all now collect. Thank you so much for your attention and time.